Welcome everyone to our very first event of Link and Share, one of the limbs of the Link program launched by the Australian National University Medical School this year. It is a program that aims to connect people for collective learning and excellence around the globe. My name is Evangeline and I'm a final year ANU medical student here in Canberra, Australia. Before I continue, I would like to acknowledge the Ngunnawal and Ngambri people, who are the traditional owners of the land where we are broadcasting to you from. I would like to pay my respects to their elders past, present, and emerging. Now, just a couple of housekeeping notes. I would like to encourage all of our attendees to ask any questions that you might have. And to do that, simply just look down at the bottom of your screen and you'll be able to see a Q&A button. If you do not wish to be identified, there is an option to submit those questions anonymously as well. And please feel free to pop in your questions at any time during the webinar, and they will be answered by our esteemed group of panel after the talks. We will keep an eye on the Q&A chat and look for some links which will attach to this throughout the event as well. If you do have any technical issues or questions after the talk, please at internet@anu.edu.au, and we will try to assist you as best as we can. And finally, please note that this forum is being recorded. Now, before we get into today's talk, which is entitled Reflections and Innovations in Medical Education, I would first like to invite Dipti Talalika, who is an associate professor in hematology, and she's practicing in Canberra Hospital. She's the lead and founder of the LINK program, and we would like to invite her to give us an overview of the program. So I'll hand over my time to you, Dipti. Thank you.
Thanks, Evangeline. It's lovely to have this first webinar of the LINK start in February this year. Welcome, everyone. I'm delighted to have so many of you here today. So my role today is to give you a little bit of a background on the LINK. Many of you did engage with our program last year and know that it actually started as the ANU COVID-19 peer support program. This program was set up when India was going through the worst of the Delta wave, and it was basically set up to provide clinical support to our colleagues there. Australia was in a very good situation there at that point. We didn't have a lot of cases then, and so our medical staff was rested and able and keen to help. So we set up a platform and put a portal in to attract volunteers and to attract people who wanted to seek clinical support. And that's how we started off. We had a very good response. Very quickly, we had about 220 volunteers that joined us from across all the states and territories in Australia. So it was really quite heartwarming and overwhelming in many ways. We started off with helping India, but soon this expanded to other countries as well. And as India the major institutions in India took over that role of providing clinical support, we found that within about 6 to 8 weeks of setting up the program, our clinical requests died down quite significantly. But we were still getting a lot of requests for education support. And that's how our webinar series was born. We ran a weekly webinar series from, I think, about mid-June to end of November without a break. And we have one more session coming up next week. So the team will give you some information about that. Our online resources have been now accessed by thousands of people. Our website has had about 12,000 page views. This is an updated graph there that you can see from across 38 countries. And we've developed a couple of research collaborations along the way. So this is a timeline that has been developed by Morrison Davies, first year volunteer medical student who is the editor of our newsletter. So you can see we set up the program on the 12th of May. On the 16th of June, we started our webinar series. We had our first medical student volunteer join on the 22nd of June. And by the 30th, we had about 150 volunteers, which quickly grew by the end of September to 220 volunteers. We had our research collaborations developed somewhere in July and September. We had a little bit of funding provided to us in August by the Australian National University. And by October, November, we had started thinking about how to take this program forward, because we had an email list of about 850 people by then from across the globe. We had a lot of fun. None of us had ever run webinars before. I hadn't, and neither had the team of wonderful medical students who joined me. So we had a lot of fun on WhatsApp groups behind the scenes, and we learned as we went. We had some very esteemed speakers, including the High Commissioner of India. We had Raman Ganga Khedkar from India. We had from ICMR in India, we had speakers from AIMS, and we had international panels where we had speakers from Fiji, from Indonesia, from Singapore, India, and Australia. So it was really very nice to have that engagement going. We had an article written about us in Australian, in the ANU setting, and we had a couple of nominations for awards, and we were, it was heartwarming to actually receive an award in December last year. So the whole team was delighted. In the last couple of months, last 3 months, I guess, we've been thinking a lot about how to harness these networks that we've created and do something meaningful. Because we have medical students engaged with this program, and they have a lot of energy and enthusiasm and idealism. I guess we found that the pandemic did highlight challenges in the health sector, but this was perhaps particularly so in resource-poor settings in every country that we came across, whether it was regional Australia or rural India or peripheral centers in Indonesia. Right now, Australia does have a lot of cases, but despite that, we truly believe that the pandemic is on the wane and things are going to become less of an issue in terms of COVID. So we wanted to pivot the program to a post-COVID phase. And we have the opportunity to adapt the program beyond COVID to provide strategic leadership, mentoring, capacity development, and learning spaces to promote value-based healthcare. So our objectives now with the link, which is the rebranding of our program, are to establish global interprofessional platforms, to nurture innovative global interprofessional collaborations, and to leverage key strengths and existing networks to achieve excellence in health education and research. To do this, we have, this is blue sky thinking, but we have come up with 4 limbs. Link and share, for which the first webinar is being held today, is the first of those limbs. So Link and Share is a peer support program for medical students, and our vision is to get medical students from across the globe together with a particular focus on Asia and Asia Pacific, to get people out of their silos in many ways, to get them thinking about what's happening in other parts of the world and really learn from each other's experience. So the virtual networking session that will happen after this will be our first such session, and I hope it really helps everyone who engages with the program. I'll just briefly tell you about the other 3 limbs. So Link and Grow is a peer support program for women health professionals with a particular focus on diversity. That's going to be the next limb to commence. Link and Learn is an education series focusing on reducing health inequity. And Link and Innovate is a program to promote value-based healthcare and come up with low-cost solutions to global healthcare problems. So those are all in the process of being developed. So thank you very much. I'll stop there and hand back to our awesome med students.
Thank you, Associate Professor Talalika. Thanks for that. And for those of us who have just joined, once again, welcome to our very first program of the Link and Share. Now, just to let you know what the agenda for today's webinar will be. So we have just heard of the introduction from the Link program, an overall view of what will happen with the program. And then next will be the core of today's webinar. So we will have 3 esteemed speakers, and I'll introduce them in a little bit. And after this session, I would like to encourage all of our audience to hop onto a different Zoom link, and we will attach that on the chat. This is what we'll call a speed networking session, where we think it's a good idea for students from around the world to really share our experience with how the pandemic has affected our learning. And we think it would be a great way to not only expand our network, but to also learn from one another. So please stay back for that. And now on to our very first speaker. So we would like to invite Professor Zsuzsa Kasiaks. She is a professor in neonatology and is the director of the Australian National University Medical School. She began her position as the director from 2021 last year, and she also previously acted as an acting director and deputy director of the school. She has also been the director of the Department of Neonatology in Canberra Hospital from 2007 to 2015. And in 2014, she was awarded with the title of the ACT Australian of the Year for her work with families to design a safe, family-centered neonatal intensive care unit and the implementation of the NICU CAM. So we're very delighted to have Professor Zsuzsa with us today. And what I'll do is I'll get Professor Zsuzsa to give us a 10-minute talk, and then we'll hand back to me and I'll introduce our subsequent speakers. So over to you, Professor. Thank you.
Great, thank you so much, and welcome all. And can I just say thank you for inviting me. When Dipti spoke to me about starting some support for COVID as an international collaborative voluntary effort, of course we strongly supported that, but what I loved about her idea is to include, our future leaders in this case, the medical students. I'm absolutely delighted to be here. Thank you so much. Now, I've been tasked to talk to you in only 10 minutes about what's happened here at ANU at the medical school during COVID. Let's see if I can share my screen. We should all know how to do this by now, shouldn't we? There we go. So I hope that you can see a PowerPoint presentation. Yep, thumbs up. Okay, great, thank you. Which is, of course, very hard. So I thought I'd give you a bit of an idea of what we've been through, and then like to focus on one topic. And I would love to hear a lot of feedback, particularly from students. So as Evangeline just said, I became director, I'm kind of the COVID director, so I became the director of the medical school in an acting position in March, just when COVID hit ANU. And without going into too many details, but I think it's fair to say that there was a lot of panic, a lot of uncertainty, and really not knowing what was coming from other countries to Australia. The Australian National University went into a complete lockdown, and I think it's the only university in Australia that completely shut its campus. And as you can imagine, for researchers, that was devastating, because their animals, their plants, their, I don't know what, anything that lives had to be sacrificed, and millions and millions of research dollars went with that. And it was very, very depressing, but it's also halted research at ANU quite a bit. At the medical school, we saw things coming and already had withdrawn students from clinical placements to regather. They were then excluded, and we very quickly went to an online learning platform. So since, particularly in 2020 and 21, not new to any of you, most teaching was online. We tried to maintain things like clinical skills, history taking and so on as face-to-face teaching. Students were able to come back to clinical placements, quite limited though. and everything such as assessment and also admissions were online. And I think a lot of good has come out of this, particularly for admissions in Australia. Prospective students have to travel a lot. They often apply at many universities. It's quite expensive for them. So to be able to do that online is not just cheaper for them, but also might be a bit easier because they can do it in their own surrounding. One of the good things that we did is we actually set up a plan. So I don't know if you've ever heard people say, oh, I'm hoping that blah, blah will happen, at the bedside. We're hoping the heart failure will get better. I'm telling you, hope is not a plan. You need to have a plan up your sleeve, and preferably. So we set up something, a business continuity plan, and that's a very big word for just a plan. And we called that Operation Graduate, because one of our critical functions, one of the most important things we needed to do in 2020 was to ensure that we could graduate students. So we needed to maintain their teaching and learning, whether it's online or face-to-face on clinical placements, because we wanted to make them doctors. So we named this Operation Graduate. And we had some subgroups that focused on teaching and learning operations and so on. And very clearly defined how we were going to do this by being very informative, collaborative, but also kind to each other, and had these critical functions, which were about graduating students, but also enrolling the next students. Quite surprising, isn't it? How, I don't know if you're aware, but back in, gotta remember when that was, maybe July or August, we had one case of COVID in the ACT, and the whole city, this is the capital of Australia, went into lockdown. We're now happy we only have 450 or so, and things are opening up a bit. So it's really a time that is changing. So in spite of large numbers, we have easing restrictions, and the university is gradually returning, and we're returning to more face-to-face teaching. However, this year, what we're focusing on, or continuing to focus on, is not just to deliver the medical program, admit students, have our curriculum going, but one of the things I'd like to talk a little bit more about is really health and well-being for staff and students. And I'd like to hear some feedback on how others have dealt with this, and what was a challenge and what you thought was a good thing. So our students, the medical students in the clinical years, are off the university campus, so they're different to other undergrad university students. And for that reason, we've put a lot of supports, I think, around them, because they're not that close to the usual supports. So each cohort of students has what we call a year coordinator, which is really a well-being academic. So that's somebody that students can contact if they have troubles with housing, access to money, but particularly if they're struggling, if they have family issues, personal issues, if they need to take leave, or they just want to chat to somebody. So these people are a great source of support, but of course, this is a voluntary service. So if students don't like them or don't feel that it's a good thing to contact them and admit that they're not feeling so well, that is a problem. We have a committee that we can refer students to, and students can refer there. Again, to students, any committee sounds very scary, and we're trying to boot students out or, correct their behavior. This is purely about support. This is purely about recognizing that these are very difficult times. Being a medical student is incredibly difficult. A lot of students are away from their family, often from overseas. And it's a pretty tough environment to be in if you've ever been in a health service. So this committee contains psychologists and lots of other colleagues that really come up with a plan to support students. And apart from that, they have supervisors of lots of times. During COVID, and since I've been at the helm of this school, we've got a lot of communication, and that's what I learned, that communication. If you thought you have communicated enough, you still haven't, is important. And we did that in a whole range of ways: newsletters, emails, tried to make some videos, to be a bit somewhat entertaining. And of course, there were the university services. So these are the student supports that are available anyway. But during COVID, very early on, we realized that students need more. Now, we did a lot for staff as well, just in case you ask a question, but I'm focusing here on the students. So teaching and learning, you've all been there online. Some of you like it, some don't. There are clear limitations to it. But the limitations are with us as well. A lot of us still love PowerPoints with lots and lots of words and graphs on it. and for us to be able to develop something that's a bit shorter, that's a bit snippier, that students can easier learn is not easy. And most colleagues would have gone to recording their sessions, which I do know students listen to at double and triple the speed, and that's probably okay. But it was also a steep learning curve for us. But some, with a small group of a team that we call TELT, Technology Enhanced Learning and Teaching Team, they really taught us how to do online teaching in a more modern and pedagogically better way. We've had drop-in sessions, though. A lot of academics made themselves available to answer those questions of those students that just struggled a bit with understanding what was online. Clinical placements were very small groups, so very personalized training. And one of our colleagues set up a website that was called Midopedia, where students could take, de-identify, of course, x-rays or lab results or something and post them, and then could have in a chat room a bit of a discussion on the patient. So what we're trying to get through here is try to teach students clinical reasoning online. So what I learned, I'm a big fan of modern teaching. I think lectures are boring and are very outdated. And even as a medical student myself, I rarely went and got into a lot of trouble for that. Some are very good, don't get me wrong, but most are really boring. And I think it's a waste of students' time when in that hour they could actually learn other things a bit better. So I've been trying very hard to get more online learning going over the last 3 or 4 years since I've been in this university and leadership position and have hit many, many walls. And I'm delighted that COVID gave us that opportunity to just do it because we had no other option, and we'll stick with that. So a lot of good things have come out, but let me talk about student well-being as well. Our colleagues, the psychologists, have developed lots of resources for students. I don't know how well they were taken up, but there was a lot that people could do from their home computer about recognizing whether they were okay or not, and a bit of self-help. And it was about being overwhelmed and what supports they need, and of course all links to just pick up the phone and talk to somebody. From academic support, we had very frequent information sessions, either with me. I met with international students and groups of students, updated them because rules were changing every five minutes, it seemed, and there was a lot of confusion out there. But what I want to get to is what the students actually did and how they stepped up. So the students have all been part of all the subgroups of Operation Graduate. The students have come together and met with me, sometimes daily, sometimes weekly, to tell us what the issues were, where students were, what they were feeling, whether the teaching, learning worked, you name it. And what they then set up was a peer support group as well, where each student was assigned, I don't know, you tell me, to reach out to another student. I don't think that necessarily worked as well because there's so many peer support, I guess, functions already within the medical student society that assigning somebody might not quite be the right way to go. But I think it did help a bit. And particularly the students that were international students that had just arrived in the country when COVID hit were my greatest concern, because I hadn't had the opportunity to form those friendships and relationships and supports that they had. So we're trying to look after them through student groups themselves. And the Medical Student Society has really worked in everything with us. I mean, I've never worked that collaboratively with medical students. They were absolutely fabulous. Anything we planned, we ran past them. Anything that didn't work, they told us. And they were definitely involved in any kind of decision-making, but were also the way to get the information back to the 440 students or so that we have. Because students then during lockdown decided that they would rather go home, sit with mum and dad, save a bit of rent, or go home to their partners or whatever not. And then states and territories locked down. We needed to track where they were, make sure they were okay, and be very clear on whether they could come back or not and what testing they would have. Because although that was all available on public sites, that was very confusing. And we helped them out. So we had these surveys where we tracked, we asked them where they were, and that helped then with getting them back at some stage. But we also asked, are you okay? Are you infected with COVID? Do you have COVID-like symptoms, or do you want to be contacted by one of these year coordinators? Not all the students answered it all the time, it was a voluntary thing, but it allowed us to also, rather than relying on students emailing us or picking up the phone, just say, I really want somebody to contact me, and then the year coordinators could do that. I mean, everything that we tried, we could do. So we've learned quite a bit there, particularly that for me, that frequent communication can happen in many ways. You don't have to have face-to-face meetings or teaching or talking to students. And I think now that we all learned how to deal with Zoom, I learned a lot from students. I think the meetings or the just getting together, chatting about things happens more often and quicker and is better. As I already said, the curricular changes that were been thought about for 3 years seem to happen overnight. There were some educational innovations that I haven't really gone through, but particularly the working with the students, I think was outstanding, and getting the feedback, which was very professional, very objective, and very informative, was outstanding. We all learned that we were trying to achieve a common goal here, which is giving the best education to medical students, making them the best doctors that they can be in spite of COVID or because of COVID in a different way. I think we all learned to live with uncertainty and to have plans A, B, C, D up our sleeve. Really, although student well-being was high on our agenda already, I think it became a big focus, at least for me and for a lot of the colleagues in this school. But we need more ideas from you on how we could do that better. Often people ask me, will the students of today be or the doctors, students of today be as good as the ones previously? And I must say, I think no doubt they have learned differently. So they haven't really learned in the traditional way. They may have missed out on clinical placements or learning experiences. However, being a doctor requires lifelong learning anyway, so I don't see that as much of a problem because a lot of the knowledge and skills will be acquired over time anyway. But I think that they have learned something that you cannot teach, that you need to experience, and that is really dealing with uncertainty, innovation, workarounds, compromise, and for the students themselves, what leadership could look like. So I'd be interested when we get to chats later on, I would love to hear what other medical schools have done to better support their students, because I'm still looking for ideas, because I think we tried very hard. This is what we came up with. I don't think it's perfect. We know that students have fallen through the cracks because we rely a lot on other students either telling us about their peers or those students contacting us. It doesn't always happen. And of course, some support is sometimes limited. If a student is struggling academically, apart from giving them a lot of supports, we can't pass them just because they're struggling. We need to sometimes then decide whether program leave or repeating a year would, in these circumstances, be the better thing. But as long as they're okay and can live with that and know that these are difficult times, and as I said, uncertainty is there, but there is a light at the end of the tunnel, I think we'll be okay. Thank you.
Thank you, Professor Shijoka. It really is an important and humbling thought that, it is something that we need to learn. And oftentimes the best way to learn is through experience, so learning how to deal with uncertainty. And thank you so much for reminding us that we as students are not the only one that's having to deal with uncertainty, but the staff and admin, medical school in general, also it's also a new thing for them. So thank you for all the hard work that you guys have put into it. So next up, I would like to introduce Professor Nina Khanna. She's an eminent dermatologist with 30+ years of experience and an author of many books. And she has been on the editorial board of many esteemed journals and has a special interest in various conditions, including psoriasis, leprosy, vitiligo, just to name a few. She's a highly revered teacher mentor with more than 200+ publications in peer-reviewed journals. And she's currently the Dean of Academics at the largest government teaching hospital in India. So that's the All India Institute of Medical Sciences, also known as AIMS. So I'd like to introduce you, Professor Nina, to give us a perspective from the Indian medical education side of things. Over to you. Thank you.
Thank you for having me over. Can you see my screen?
At the moment, we're just seeing your
No, because I
little
could
files.
share it earlier.
Do you want to try resharing it again?
Yeah, let me do that. Can you see it now?
Not yet.
No.
Professor Ninaya, where will you have your current cursor? If you try clicking on that, does that
So
bring something
I
up?
shared it earlier. Just let me stop sharing and reshare
Okay.
it.
Yeah,
Yeah, let me
sure.
do that. You could see it earlier, no?
Yeah,
Okay, there we are. Can you see it now?
beautiful.
Perfect, perfect.
Right. So I'm going to be talking about the experience from India in medical education and COVID-19 pandemic. Yeah, so a bit about how the student progresses in a medical school. We have about annually about 1.6 medical aspirants who vie for about 89,000 seats. Eventually, half of them can postgraduate, and about only 5% can do super specialization. So it's a tough battle. Our students do 1 year of preclinical, a year and a half of paraclinical. At that time, they also rotate clinically. They have 2 years of clinical posting where they're exposed to community medicine. They finish their final prof and do 1 year of compulsory internship. So this is the curriculum. Now, medical education all over the globe is a complex interaction between teachers, facilitators, students, and the teaching environment so that the student can get knowledge, attitude, and importantly, skills, both clinical and communication skills to improve patient outcomes. That is very important. But for the last 2 years, this whole thing has been hampered by the pandemic. The pandemic has not only affected education, but has actually almost brought life to a standstill in several parts of the globe. Last year was a tough year for India. Hopefully, we have, I think, overcome even the third peak now, and we're actually waning. The number of cases are waning. We had several problems. The lockdown was the most important. So there were no physical OPDs. There was complete shutdown. The physical classes were completely off. There was restriction of non-COVID health services. And importantly, a lot of our residents, a lot of our students were reallocated to COVID dedicated areas. So this actually hugely compromised our training. There was delay in entry into the system. So our batch of July 2021 is now entering. In the last 1 week is entering postgraduate and undergraduate courses now. So there's almost a 7-month delay in entry into the system, resulting in delay in assessments and lot of mental health issues because of deprivation of social interactions, the isolation due to COVID, quarantine due to COVID, and some of us have faced personal loss. And that has actually impacted the mental health of a lot of students. And as rightly pointed out, this has actually been responsible for a lot of delay in learning and appearing in assessments. And we have had to actually deal with these issues. And we have had yoga classes for the students. We've put in meditation classes for the students. We have a students wellness. We have actually enhanced the wellness clinics in the hostels. But this problem is still there. The mental health issues are still there. Majority of medical schools managed to rapidly switch over to online learning. And the initial feedback on online teaching was very euphoric, with student satisfaction and on the quantity and quality of education being high. The attendance was high. We at AIMS also were equally quick to adapt to online teaching. It was easy for lectures to be switched online. The challenge was with practicals. So how did we overcome the challenge? Now, in the preclinical side for teaching the undergrads, we video captured cadaver dissections and demonstration. We gave them institutional access to online video atlases. We online demonstrated micro and pathology slides. We tried to get the feedback from the preclinical departments on the experience of the student perception on synchronous virtual teaching vis-a-vis person-to-person or face-to-face teaching. And apart from the convenience to attend virtual sessions, on all other parameters, actually a face-to-face teaching was better than the virtual session. However, certain activities like symposia, seminars scored equal in virtual versus the face-to-face. On other parameters like the journal club and group discussions, face-to-face was superior. However, interestingly, what we found that if we tweaked the format a bit, like we made it a structured format, the acceptance, the student acceptance for video, for the virtual group discussions increased. When we came to teaching clinical side to the undergraduates, of course, it was easy to switch over to online mode for the lectures. However, because of restricted OPD and social distancing, the clinical teaching did suffer, but we did manage to have online case discussions. We combined several semesters together because there was a time loss because of the COVID. So we combined classes for the undergraduates and early entrance into the residency. We combined their classes. We threadbare discussed the few patients who dared to attend the OPD because there were so many restrictions, movement restrictions in the country. The surgical procedures were streamed from OTs, which had the facility to do so. This is the experience from the dermatology department, which is my core specialization. So lectures, seminars, journal clubs, thesis review could easily be switched over to online mode. Clinical case presentation and spotters, we had to delve into our collection of images and we asked the residents to present and discuss some of these patients. We also had short online discussion on the few patients who were coming to the restricted OPD for the benefit of all residents, including those who were posted in the COVID duties. Dermatopathology was easy to switch online. Dermatosurgery, as I mentioned earlier, we did show procedural videos and online streamed the surgeries which were being done. What was challenging is when we actually did a national level workshop, which was attended by 1,500 delegates, we live streamed it. This was way back in January 2021, and this was very well appreciated. Assessment is a very integral part of training. And we usually have a written, a viva, and a clinical evaluation of patients. The patients, the residents are even given patients either with the history or without the history, something which we call spotters or making a spot diagnosis. In the pre-COVID era, we had the standard format for written and viva examination. For clinical evaluation, we would pick up 10 spotters per patient from a very bustling OPD. This is the look of our OPD in normal times. But during COVID, our OPD was a very lonely OPD with a stray patient coming in. So we had to reinvent the assessment system. So what we did was we divided our residents and examiners into 5 groups consisting of 2 examiners, 4 or 5 residents, and 2 senior residents to coordinate the exam. And we again delved into our collection of pictures and we allotted each resident 8 PowerPoint slides online, the diagnostic difficulty of which were appropriate to the level of the training of the resident. For the final year postgraduates, we hybridized this. We asked them to work up live cases who were admitted in our inpatient and evaluated them virtually. Now, Viva is where we really innovated. So what we did for the Viva exam, Viva is an oral evaluation of the theory knowledge. We divided the residents and examiners into 2 equal groups, and we created 11 virtual stations, 5 Viva stations and 6 waiting stations. Each Viva station had a unique Google Meet link and was manned by 1 examiner who was assessing on pre-assigned topics. The residents started from 1 station and moved every 15 minutes. And this worked out to be fail-safe unless the Viva at a particular station lasted for 30 minutes, which didn't ever happen. So eventually each examiner interviewed 11 residents and each resident faced 5 examiners. So when we got anonymous feedback, both from the residents and the examiners, the residents actually thought this was a less stressful method of evaluating because they did not have the examiner staring down at them, and they could actually be evaluated on a variety of cases. When we looked at the bar diagram, we found that for the Viva, the residents were very happy with the online mode, while for the clinical exam, they all wanted an online mode. So if you look at the Miller's pyramid, this was another innovation we did during the COVID time. If you look at the Miller's pyramid, it is only in the dust triangle that a doctor truly performs. So what we have done is that the latest modification is that we have video recording of the surgical procedures which are performed by the residents, which are evaluated by the faculty. So in the last 2 years, there have been a plethora of publications on the effect of COVID-19 on medical education at undergraduate level, at postgraduate level, and at what is the effect of COVID on healthcare professionals, and what would be the preference of teaching in the post-pandemic period. Despite the cons, a lot of disadvantages and some advantages, I think what online and alternative and teaching did was that we continued to teach and we continued to learn in the last 2 years. And in a country like India, where there was a lot of resistance to e-teaching and to telemedicine, we have made the shift. So I would strongly think that COVID-19 has been a catalyst for transforming medical education and health delivery, even though there was a little hampering in the initial phase. Thank you.
Thank you, Professor Nina. Thank you very much for sharing that. And what an interesting perspective, especially when you're talking about learning the pathology side of dermatology. We've got a question on that, but we'll address it towards the end. Thank you. I'll just quickly share my screen again. All right, so next we have our third and last speaker for this part of the webinar, and it is Associate Professor Komang, and he is an associate professor of the Department of Microbiology in Indonesia. He completed his MD from Udayana and Master of Medicine at Gajah Mada University, as well as a PhD in medicine at Udayana University. He was the program convener for the Bachelor of Medicine and currently serves as the Dean of Faculty of Medicine at Udayana University. So I'd like to invite Associate Professor Komang to talk with us today.
Thank you, Ms. Wong. Good afternoon, everybody. Let me share my Okay, can you see my screen?
Yes, we can.
Yeah, thank you. Good afternoon, everybody. I'm from Udayana University, Faculty of Medicine. Okay. Okay, our faculty is the first public medical school in Bali, founded in 1962. And at this moment, we already have 2 other medical faculty in Bali. So now in Bali, we have 3 medical faculty. Our medical faculty located in Denpasar City, the capital of Bali province. Now we have around 1,500 students. As we know, Bali is a famous tourist destination, and many or most of people depend on tourism for their lives. So this factor affected very much by the COVID-19 pandemics. The course of COVID-19 pandemics in Indonesia, especially in Bali, is up and down, as Professor Susoka mentioned before, now we live in uncertainty. COVID-19 pandemic hit Bali first time on March 2019. And from that time, the cases is up and down. We have the peak on July to August last year. And after that, the cases is reduced, but as the Omicron variant is introduced, now the cases is increasing again.
Sorry to interrupt. Just wondering, are you changing the slides? Because we're not able to see it change.
No?
No,
Not
not
yet? Yeah, okay.
I think you should put it on full screen, then it'll move.
Yes, it's already full screen, I think.
no,
On
We
my
can actually,
story screen. Is it?
it's not
I'm
full
sorry?
screen.
we're not seeing it full screen. Do you want to try and swap the screen that you're being shared if you're using two screens? Oh, now it's moving, but not full screen yet.
Okay, what's about that?
We're still not seeing full screen, sorry.
In my screen, it's already full screen. Sorry, what's happening?
Dr. Komang, maybe stop the share and try resharing.
Okay, yes.
If that would work.
Yeah, it worked for me. Yeah.
How about this?
No, not able to see.
No?
Maybe if you can just walk through the slides, should be fine. If you try going to the next slide.
Because on my screen, I have already seen it's on full screen. I'm sorry.
No, that's okay. That's
all
okay.
right.
If you can just walk through the slides.
Yes.
Try changing
Is
the
this
slides.
okay for this?
Yep. Try changing to the
okay.
next slide.
Yeah, okay, thank you. I'm sorry.
No. All good. All good.
Okay. From January this year, the cases, especially Indonesia in general and especially in Bali, already increased. Yesterday in Bali, we have about 1,900 new cases. So I think it's not a good news for us. Yeah. Okay, what's happened during this pandemic to our academic activities? For the student, they will experience a change in academic environment because they have to stay at home, not come to the university to have an academics activities. Since March 2019, as the first cases found in Bali, we are done all academic activities online from March to August 2019. All activities, including our clinical rotation, all activities are done online. But from September 2019, the lecture is still online, but for clinical rotation is conducted offline, and in academic phase for laboratory practice and also the clinical skills, we did it offline, including our examination for OSCE. Another problem is a financial problem. As I mentioned before, mostly people in Bali depend on tourism for their life. As the pandemic hits, tourism is locked down. Most of the parents will have a financial problem. This will affect the capacity of the parents to pay for the tuition fee. That's another problem for us here. Another problem for students is a psychological issue, because They have a limitation, social relationship with others, with their college. This raised a psychological issue. For the faculty, we have to facilitate the student coping the situation. We have limitation in resources because we totally not ready to face this pandemic. So what we do, the first, the principal mention for us is safety for everyone involved in the academic activities, students, the lecturer, and also the other. So we have to develop new protocol. We have to adjust our standard operating procedure. We have to shift our financial policy. For teaching and learning activities, we are conducting our activities by hybrid method. It's a combination of online and offline activities. And also, we adjust our activities both on academic and on clinical rotation. On clinical rotation, we only give the activities for bedside teaching and also for polyclinics as an offline. The other is conducted online. Case report, morning report is done online. Also, the rotation only conducted in our main teaching hospital. We didn't send our student to have a clinical rotation to our remote teaching hospital. But we still have learning outcome as our guide in all of our learning activities. The faculty also provide the technology and information support because not of our staff are familiar with this new technology, especially in information technology. Faculty provide the technical support and also staff development to adopt this new technology. For student support, we have an adjustment of financial policy. From our government, we have policy that we give our what is called new financial policy for the payment of the tuition fee. Also, we provide a counseling unit because we found several psychological problems faced by our students in this pandemic era. This is several activities are our improvisation and innovation in conducting our academic activities during this pandemic. We use online course for lecturing and also for small group discussion. We have still offline activities for clinical skills and also for laboratory practice. This is our evolution during COVID-19 pandemic, both for academic phase and also in clinical rotation. As the pandemic hit at the the beginning of the pandemic, all of academic activities are conducted by online teaching and learning, including our basic clinical skill and also for clinical rotation. And then as the cases reduced, we conducted our basic clinical skill on offline activities. And then still now, we do it by hybrid method, combination of online and offline. But mostly from this year, this semester, mostly we did it by offline method. In clinical phase, for clinical rotation, at the beginning of the pandemic, all clinical rotation was stopped. All activities are done online. And then as the cases reduce, we start to make it hybrid, and then offline, but no night duty. And now we started to go offline and night duty just until 10 p.m. But as the case of COVID-19 pandemic, especially the Omicron variant, is increased since this January, looks like we will back to online for learning, for lecture, and also for small group discussion. From the rector, the policy from the rector from this semester, the activities will be done by offline. We have tried for one week. I'm sorry. Since this last week, we have started our academic activities offline. But as the cases is increasing, from next week, we will back to online activities, especially for lecture and also for a small group discussion. This is not a good news for us. Okay, so from what the take-home message we can learn from this? The first is safety. Still, safety is our priority. Safety for students, safety for lecturer. Second, the quality is the standard. We didn't reduce our standard. The standard is still the same as the non-pandemic era, but we adjust the method how we can get the standard. But the standard itself is still the same. The third, we have to adapt. Adaptation is the key. And the fourth, the humanism also is the heart. Because in the situation, many of our students have the psychological problem in the situation, so we still need a humanism as the heart of our academic activity. Okay, thank you.
Thank you, Dr. Komang. Thank you very much for sharing that from an Indonesian perspective. And I think it's important as well because you highlighted a very different thing that I wouldn't have thought of, and that is because of the economy in Bali, financial difficulties is a real problem. So it's good that financial adjustment policy was able to take place. So now we move on to a Q&A session, and we would like to invite all three of our esteemed speakers back. We have quite a few questions in the Q&A box, and Professor Jujuka has already kindly answered some of them. Just let me bring them up from my end. So maybe what I'll do is I'll read off the question that can be addressed to all deans, and that is, what do you think will be the biggest impact in the long term of COVID on medical students? And I'll open up the floor to anyone that would like to start first. Dr. Komang, would you like to tell us a little bit about what you think will be the biggest impact in the long term of COVID on medical students?
Okay. What I'm being afraid of on the long term of this COVID is the reduced competency of our graduates, because not all competence can be achieved by online course. That's our biggest concern, I think.
That's a good point. Anything to add from Professor Nina and Professor Jojoka?
Yeah, I think, the soft skills which you get to learn when you are handling a patient, that is something you will not be able to get online. And, the empathy, the ability to counsel them, the, handhold, the body language of the patient, that doesn't come through well when you are doing either, telehealth or you're doing an e-learning program. Those things will be difficult to imbibe. And even surgical skills for that matter, how much ever we tutor you on videos, unless you do it yourself. I mean, I projected the Miller's pyramid. The does part is the most important part, I think. So doing it, writing the prescription, doing the surgery. And because I'm basically a dermatologist, so I can, we have dermatopathology, we have dermatosurgery, we have, obviously we have dermatomedicine. All those skills are, theoretically easy to impart online, but when you really sit down with the patient, the patient cannot even converse as much as he would want to when you're delivering telehealth. So I think that's the big gap which we'll have to cover somehow in the coming times.
So I think the question was impact. I agree with my colleagues, it's difficult. And what we're trying in Australia now is to liaise with the hospitals, where those COVID students now becoming COVID interns. Medicine is lifelong learning, and it's time now that the health services step up and pick up those skills or whatever not that students have missed out on. And I'm sure within a year or two they'll be okay, but I think there needs to be a really good understanding that these are different students. However, I just want to come back to what I think is a good thing about this. If you think about the history of medical education, the early doctors hundreds of years ago, they were apprentices. They were straight to work. There was no oversight of a curriculum. Teaching was higgledy-piggledy until a big, obviously, review came along. And I think it came, at least in the Western world, mainly from the States. And I've worried a bit that it's kind of swung the exact opposite, that students have become not just learners, but passive participants. They are not part often of a clinical team. And I think this has really given us the opportunity for students. It was difficult for them. There was, at least I can only speak for the students at the medical school, a lot of fear to step up. They didn't want to go into clinical environments because God forbid they could get COVID. What do you mean you want us involved for pay, mind you, to vaccinate and to test? And so, well, you get paid. This is actually part of the service that you have to provide, and you can provide through your education. And guess what? You're probably more protected there than if you go down to a restaurant or a coffee shop and sit and have a coffee with your maid. So I'm kind of hoping that the inclusion of students in the clinical environment as junior doctors, yes, they're students, but in the end, they are our future peers, is maybe swinging back a little bit, that we can see them as not just standing around and being very annoying and being bored, really, by what we do, but participants. In a few states here in Australia, I don't know if you've heard about that, they were able to employ students as what they call assistants in medicine. So these were final year students that could spend, I think, up to 30 hours a week paid to work as junior interns, so to say. Something that, nursing students have been able to do for decades, because the minute you've done 1 year of nursing school, you are an assistant in nursing and you can work weekends and night shifts and whatnot in hospitals and aged care facilities and so on. As a medical student in Australia, you can't do that. I was able to do that in Germany, where I trained, and I learned my medicine essentially as a student working night shifts and so on. So now that we've implemented that, and students really, that they can learn their lectures and their knowledge overnight, or when we're all asleep. At least that's way past my bedtime, but students seem to be learning at different times. And they have a life, and we need to be respectful of that as well. They have financial issues, you talked about that, but really to include them in the clinical environment, be very respectful that they're juniors, but they can do things. They can admit patients, take a history. That's where they can practice that. Be part of the team. In Australia, I don't know how it is in your countries, but as interns, they're essentially computer slaves, ordering right, left, and center. They can do that as students. We can teach them how to do that. And they can be a very, very important part of the team, which means that the next level of medical professions, they can step up. So the interns can help the residents better, and the residents, the registrars, and the registrars, so it all lifts up a level. So I think there are real opportunities here to have students not just as the passive learners, but active parts of our team. I'm just trying to see the positive here.
No, that's great, and that kind of brings me to a good segue. So now that there is a shift of medical students being involved more in the clinical setting, the one question was, in terms, what is the vaccination rate in clinical training students and interns and registrar, and what protocols are in place if someone happens to be positive with the Omicron variant?
I might start off from Australia. So our students, this, have to be vaccinated before we let them into the program, and before they're all vaccinated. The students in Australia, depends on which university or hospital you go to, are by now all exposed to patients with COVID. But in Australia, the situation is that not everybody who is COVID positive is in hospital because of COVID. They're there because they've got broken legs and diabetes and blah, and happen to be COVID positive, okay? Whilst in 2020, we excluded all students from any contact with a COVID positive patient. We don't do that anymore, only if they have respiratory symptoms. But even there, they're probably the best protected with all their gear. If a student becomes COVID positive, which is quite likely, and we know they have, just like us, professional staff and clinicians and academics have, they need to tell us. That gets recorded. They're excluded from clinical services for quite a while, again, depending on the state and territory that you're in, but they might not come back, even if they recover quickly, to their clinical placement for at least a week or two. And if we know that they are infected with COVID and have to stay at home, and then as I said, our well-being academics are encouraged to reach out to them. So it happens. It seems to be part of life at the moment. It was very different in 2020.
Yeah, and I noted that Dr. Komang also said that that's the same requirement in Indonesia to have 3 shots of vaccination.
Yeah, all our registrar and clinical trainer are already vaccinated with 3 shots of.
Yeah. Okay, great. Now I've got a question for Professor Nina. You showed us slides early on in your presentation on dermatology pathology, and you said that they were screened online and students can have a look what the thing looks like underneath the microscope. But are you planning on retraining students for more wet lab skills? So things, for example, with specimen processing, how to use the microscope and then special stains, etc.
Yeah, the dermatology residents don't get trained in the bench work. So they are actually looking at only the slides and interpreting the slides. So whatever clinical cases we biopsy, we get the slides back to us and then we look at the slides. So our residents are trained to do that. So the pathology residents are the ones who do the bench work, and our residents are not trained to do bench work, so they don't have to go back. But yeah, handling the microscope, and we have several types of microscopes. We have the dark ground microscope, which is used for diagnosis of syphilis. Yeah, we plan to train them. Actually, now the training has started. We are back to almost normal numbers in the OPD. So we are back to, as I said, our COVID restrictions fluctuate with the COVID numbers. So they're inversely related to the COVID numbers.
Yeah. Okay. And maybe I'll just talk about one more question, just with the sake of time. So in terms of AIMS, so AIMS was involved in educating health professionals across India during the pandemic. Did medical students at AIMS gain from that, or were they involved in delivering educational content as well?
No, the AIMS graduates, the undergrads and the postgraduates had to undergo a mandatory training in COVID. So we have a module for that, and everybody had to be trained on that. But they were not directly themselves delivering the content. However, when we were having the COVID wards, the COVID exclusive wards, the medical students pitched in to give information to the relatives and counsel the relatives. So that was the role which some medical students volunteered to do, but it was not mandatory for them to do.
Great, thank you. And because of time, we'll stop it there. Again, I'd like to thank all of our speakers for joining us today and really sharing the different perspectives of how COVID has impacted on medical education, both positive and negative. So thank you again. I would like to give a quick plug on the different LIM program that Associate Professor Dipti Talatka has mentioned at the start of this session. So next Wednesday, the 9th, there will be a webinar delivered by Associate Professor Sanjaya as well as Associate Professor Niraj. And they will be talking about the Omicron variant, giving both the Australian and Indian perspective. So it is an exciting talk, is one that I'm actually looking forward to learning more about. And to register for that, I'll invite you guys to head over to this link, and I'll get one of my colleagues to post a link on the chats as well. And if you happen to know that anyone who is interested, please also circulate that link to your networks. And now for the next part of this exciting session. So it will be our speed networking session, and that's where our medical students from around the world can interact with one another. And I'll leave it to Sushant to tell us more about it.
Hello, everyone. First of all, thank you for the speakers for the great speeches and talks. It was just enlightening to hear how quickly the medical school changed. And I'm very excited about how medical schools have started using these technological platforms to actually enhance medical learning. Because I personally think that we are lacking in those just using these technologies for more active learning, more clinical reasoning, and just being more efficient with the studying. So now to the next part of the event is the speed networking event. So basically it's a social networking with medical students. I'll in a second, you guys should see a new link in the chat. So there's a new link for the SpeedNet. So please join this link if you want to get involved in the networking opportunity where we just get together, we talk, we get to know each other. So please do that in the next 5 minutes, and I'll see you guys in the new link. Thank you.
Thanks,
Thank
everyone.
Thank you.
Thank you.